Thank you very much for inviting me to this interesting session on fluid resuscitation. And the question asked to me is, can we measure capillary leak? A disclosure, research of studies that we do at NYU is supported by the Daxor company that makes a device to measure total blood volume and transudation. And I have been paid in the past for a consultancy for the same company. Now, the methods to measure capillary leak is basically based on a simple principle. You have a tracer inside the circulation, and you measure the disappearance of the tracer. The oldest one is Evans Blue, and that was already introduced in 1915. It's highly water soluble. It binds strong to albumin. Only a very small proportion is free in the plasma. And so if you inject Evans Blue, you basically label the albumin with the Evans Blue. It's eliminated from the circulation by the liver, and it has been used in the past to measure blood volume, red blood cell volume, and even cardiac output. And especially when looking at vascular permeability, they looked at blood-brain barrier. The problem with Evans Blue is that everything turns blue. And there's also limited reports on some toxicity. So basically, the Evans Blue technique is replaced by radio-labeled albumin when you do it in the context of plasma volume and stuff. Evans Blue is still used in cancer surgery and other surgeries. So the albumin transudation use of a tracer is based on radio-labeled iodine albumin. First introduced in 1946, the same group, Gibson, also studied the Evans Blue, but then switched to radio-labeled albumin. It's based on the same principle. So instead of labeling the albumin inside the patient, you label the albumin outside the patient and then inject it into the patient. So you need much less tracer in this case. Currently, only one FDA-approved technique is available for bedside measurements. Basically what you do is you inject the tracer and do, after a baseline measurement, you inject the tracer, you do repeated measurements after you allow for mixing of the tracer in the blood. And by having these additional measurements, you put them in the device measures the decay of the radio-labeled iodine albumin. And from the decay in the radioactivity, you can measure or basically calculate total blood volume when you take this regression line to T0. Now, the report is basically focused on blood volume. Yeah, you get blood volume, red blood cell volume, and plasma volume. And this is how it has been used in clinical practice. Currently, it's frequently used by cardiologists in patients with heart failure, but there are a few studies in critically ill patients. This is the group from Hawaii, where they randomized 100 surgical patients with circulatory failure to be either managed with total blood volume measurements using the albumin technique or a PA catheter. The goals of resuscitation in both groups were similar. They aimed for a blood pressure, they aimed for a heart rate, for a urine output, a decrease in lactate, optimizing mixed venous oxygenation, and the oxygen challenge test. In the blood volume group, they aimed for a total blood volume up to plus 16% of ideal body weight, and a red blood cell volume to be maximum minus 20% of the ideal for a healthy individual. So basically, if this was more than 16, they stopped fluids and gave furosemide. If this was more than minus 20, they gave red blood cell transfusion. They measured the parameters of the tracer total blood volume in the pulmonary artery group, but didn't give the results to the doctors. First measurement was done after the initial resuscitation, as you cannot measure stable blood volume while you're actively fluid resuscitating patient. And so you have to wait until the patient is at least stable enough to have half an hour of non-intervention to have a blood volume measurement. What they found in this group is when they, after the study was completed, looked at the control group where the doctors did not have access to total blood volume and red blood cell volume, what they would have done had they known the results and used the protocol that they used in the blood volume group. And as you can see, this is the main difference. In 30% of the patients, they would have stopped fluid resuscitation and give and or give diuresis had they known the results. And in almost 30% of the patients, they would have given more red blood cell transfusion had they known the result of the total blood volume. So that would have resulted in a change in clinical management. If you look at the outcome of the two groups, and remember it's only 50 patients, so we cannot make a lot out of the result, but there is an indication. There is a significant difference in mortality, 26 versus 8%, and it seems to be driven by the development of multiple organ failure. And then it makes sense, because if the main problem is related to volume, and we know that overhydration, too much fluids, tissue edema, in many studies has now been associated with a worse outcome in multiple organ failure, then this could be indeed driven by volume, fluids, and the development of organ failure. Now, can we measure capillary leak? Yes, we can, because the report also gives you the albumin transudation rate. It's an analysis of the slope, as I showed you. The radioactivity in the samples is decreasing, and the only reason it decreases is not the decay of the radioactivity, but the disappearance of the labeled albumin from the circulation, which is a surrogate for capillary leak. And so the report also gives you the transudation rate. But the question is, okay, you get this number, but now what? What the group from Hawaii also did is they retrospectively analyzed in 160 patients, of which 30% died and stayed a long time in the ICU. They retrospectively assessed the results of the transudation rate, and they defined a persistent increased transudation rate if they measured more than 0.25%, which is normal, for more than one measurement. So they took patients where they had at least 3 measurements. If 2 of these 3 measurements, at least 2 of these 3, more than 3 measurements, were showing increased transudation rate, they said this patient has persistent increased transudation rate. A little bit complicated definition, but I think it makes sense. The majority of these patients had respiratory failure and or septic shock. They were sick, the Apache score was increased, and they found that if they had this increased transudation rate for more than one measurement, so for at least 2 measurements, the mortality was way higher, 42% versus 24%. This study has been published only as an abstract and not as a full paper. So it seems as if this albumin transudation rate is persistently high, you'll have higher mortality. The question is, why do you have this increased capillary leakage transudation rate? From this study, in 41 stable patients that came to the hospital for a checkup, so no acute problems, these 41 patients on peritoneal dialysis were measured with the 125 iodine albumin. And so they injected in the same way the albumin and did subsequent measurements. And they found 3 clusters in these 40 patients. And the patient with the highest transudation rate had activation of platelet, as you can see here. And so these are the indicators of platelet activation. And so in this cluster, there's a much more activation of platelets than in cluster 1, where there is more activation of inflammation. Remember, the patients were not sick; they were stable patients, and so they said in their conclusion that this exploratory analysis indicates that this barrier function is decreased in dialysis patients, but if it's very high, it's more related to platelet activation than inflammation. And now it becomes interesting in our corona COVID-19 pandemic, because we know that a lot of these patients have endothelial damage. This is just a small study just published in Critical Care Exploration, and they looked at non-COVID patients and COVID patients, only 10 patients. But what they showed is that the COVID patient had much more endothelial damage. As you can see here, syndicon 1 as a measure of endothelial damage is increasing significantly where in the COVID patient, but not in the non-COVID patients. And we have studied the blood volume of these COVID patients in 6 patients because we had a question whether these patients were hypovolemic, euvolemic, or hypervolemic, given the limited circulatory monitoring that we did. 6 patients, and we measured them on different days, 2, 7, 11, 13, 14, and on day 20. 4 of these patients died. The 2 survivors stayed in the ICU up to 3 weeks, one 10 days, the other one 22 days, and an additional hospital stay of 24 and 19 days, and then they went to a recovery home. All non-survivors developed renal failure, and only one survivor, the one that we measured on day 2, came to the hospital with severe hypernatremia and a history of hypovolemia, vomiting, and diarrhea. He came in with increased creatinine, AKI2, and made a full recovery. Only one of these patients was on vasopressors while having a normal lactate level. So this is the 6 patients. All had a positive fluid balance the day before we were measured. All were producing urine, and all had a very significant fluid balance since admission. This is the individual patients. As you can see, only one patient required norepinephrine to maintain a minimal blood pressure. All the others were having adequate blood pressure without vasopressors. All had significant urine output the day before the measurement, 3 of them with the use of diuretics. Now, in this scheme, we see the day of measurement and the fluid balance since admission. So this patient was measured on day 2 and had a positive fluid balance of 4 liters since admission. This patient was measured at day 20 of his admission and had a 10-liter positive fluid balance. Then we asked the doctors, what do you think is the status? So hypovolemic, hypervolemic, this is the clinical assessment, and then we measured. And as you can see, in 2 patients where the doctor thought it was hypervolemia, the patients were actually hypovolemic. And the patient where the doctor thought he was hypovolemic, the patient was actually hypervolemic. And only in 1 patient, the doctor was correct. We looked at the results of the transudation rate, and as you can see, over time, the transudation rate increases. If you do a linear regression, you get a very significant linear relationship between time in the ICU and the transudation rate. If you look at the transudation rate and the total blood volume, it seems that the more transudation, the higher the transudation, the lower your total blood volume, so the more likely you are to be hypovolemic. And when you combine the two, this makes perfect clinical sense. Increased leakage of albumin results in more hypovolemia. Now, of course, this is limited number of patients. In conclusion, blood volume measurements are clinically feasible. It seems to be associated with improved treatment and outcome. We can measure the transudation rate, so capillary leakage, as this is an element of blood volume. The increased transudation rate is associated with platelet activation in peritoneal dialysis patients. And the clinical assessment in at least COVID patients is way off if you use total blood volume measurements. And an increased transudation rate is associated not only with time, but also with blood volume. Now, as I said, uncontrolled study. So we started a multi-center study to confirm the current findings and to study the transudation of crystalloids as well, because as you may remember, in the first days it seemed to be normal, the albumin leakage, but still we have ARDS-like syndrome in many of these patients. And if we can confirm all of this, these findings could have an effect not only on the type of fluids we would use, but also maybe on the treatment of platelet activation and treatment of endothelial barrier function. Because if you have a measure of endothelial dysfunction and leakage, you can study the effect of treatment. Thank you very much.